purpose, and I request the participants to kindly mute yourself and kindly post your doubts and queries in the chat box. It can be taken up for discussion at the end of the session. Over to the speaker, Dr. Prasanth. Over to you, sir. You can share your screen, sir. I have made the.
I hope you can see my screen.
Yeah, sir. Your screen is seen.
Thank you. First of all, I'd like to thank Vishnu Bhatt sir, the great teacher, and like we've been really inspired by him from undergraduate days. Thank you very much, sir, for the opportunity to share some of these thoughts on this topic. We always welcome an opportunity to discuss about this is a topic which is very often discussed about. It is a relatively rarer form of treatment for many cancers, at the same time very important modality of treatment for a particular types of indications. So in my today's talk, I'm going to talk about stem cell transplantation. Briefly discuss the principles, the procedure, and the indications. Please feel free to ask questions at any point of time. I've tried to tailor this to a general audience to give the overview. But if you want me to go into specifics, I'll be happy to do that. After I talk about that, I'll also briefly share the experience from our own center regarding the stem cell transplantation. And as is the brief of my talk today, I will briefly towards the end discuss about newer modalities of cancer therapy. So when we talk about stem cell transplantation, first we must understand what are these stem cells. So, as we know, the embryonic blastocyst, when it divides into multiple embryonic stem cells, which differentiate into the endodermal, mesodermal, and ectodermal components. And from the mesodermal components, you have this component of hematopoietic progenitor cells, which is the major stem cells which is used for stem cell transplantation because they are easy to harvest, easy to procure. All the other types of stem cells are not generally used for therapeutic purposes. The interesting thing about the stem cells, even though they are partly differentiated into hematopoietic stem cells or mesodermal cells, they have the potential within them to differentiate and into other tissues. However, having said that, at this point of time, use of the stem cells, the hematopoietic stem cells, for other indications other than what I'm going to talk about. You might have heard of stem cell therapy for cardiac problems, ischemic heart disease, even for paraparesis, spinal cord dysfunction. So there is a lot of research happening on use of stem cells to modulate these kind of situations. However, currently all of them are in the experimental domain, and hematopoietic stem cell transplantation, as I'm going to, is the current standard indication for stem cell therapy. So, as I told you, the hematopoietic stem cells can have the potential to evolve into multiple types of cells in the blood, primarily into the myeloid series and the lymphoid series. And basically, from the single stem cell, the entire gamut of cells can be reconstituted in the body in a proper time. So again, there is an important thing to understand. When we talk about hematopoietic stem cell transplantation, the commonly used term is bone marrow transplantation. So, but that's because the source of these stem cells is usually the bone marrow. When this procedure was first done, these stem cells are harvested from the bone marrow, as you can see the picture here. Just like we do a bone marrow test for diagnosis of hematological cancers or hematological conditions. In a similar way, you can suck out the marrow, and the marrow is in these hematopoietic stem cells. This is how the procedure was originally done, and because of that, the common term used this is bone marrow transplantation. Having said that, in the current era, the source of these stem cells is not usually the bone marrow. What we do is use certain growth factors which are administered to the patients, by which these stem cells are mobilized from the bone marrow into the peripheral blood. And from the peripheral blood, as you can see here, using a simple FFF procedure, just like we do a placental or something like that, these stem cells can be harvested out and hence and subsequently used. And as you can see here, from 1991 up to 2003, this graph shows that the source of stem cells for the stem cell transplantation procedure has changed from bone marrow into almost completely peripheral blood stem. There are obvious advantages to use the peripheral blood stem cells. Primarily, it is the patient comfort, because a bone marrow harvest procedure requires the general anesthesia. It can be quite painful for the, and it can be you require general anesthesia, you require an operation theater, whereas a peripheral blood stem cell harvest is a very simple procedure which can be done in the blood bank. Also, generally, the quality of stem cells which are derived are better in the peripheral blood harvest. Because of that, the terminologies have also changed. Earlier, it was always called as a bone marrow transplant, and then bone marrow and blood and marrow transplant. And the current preferred term is hematopoietic stem cell transplantation. So, briefly, what happens is you have a donor from which these stem cells are harvested from the peripheral blood. As you can see, it's a simple FFF procedure. And these stem cells are then infused into the recipient. This is how a stem cell product looks.
Take this for upload.
The stem cell product
usually, what time it is reaching that attendance every day, reaching 4 o'clock yesterday without classifying.
Sir, your speaker is.
Oh, sorry.
So the stem cell product, this is how a stem cell product looks. It looks like a bag of blood actually. But actually the component of blood or the RBCs in this is very, very low. It just looks red. Actually, the hemoglobin component will be less than 1 gram in the harvested product, because the FFF machine almost completely excludes the RBCs when this is done. So when did we start doing this procedure? So this concept was there a long time back in the 1960s, or even before that, during the World War. And what happened was people used this very toxic chemical weapons like the nitrogen mustards, and a lot of people actually ended up with marrow ablation. And this concept was there that ablated marrow, you could use cells from a donor to try and recover the marrow. However, there are a lot of challenges. Just like a kidney transplant, you have to match. So without matching, if you give the stem cells, first of all, the stem cells just won't survive in the donor, in the recipient. And when the stem cells do recover and reconstitute, there will be a lot of problems, logical problems with the recipient. I will discuss about that in detail. So what was required? A full matching process, just like we do for kidney transplant or liver transplant, and HLA matching. So that the recognition of the HLA system was only in the late 1950s and 1960s, and hence only after this the procedure was safe to do. And the clinical program started in 1970s, and the first transplant happened around that time. Successful transplant was done in 1968 by Dr. Donald Thomas, who was a clinician who worked initially in Minnesota and subsequently in Seattle. He was awarded the Nobel Prize in Medicine for his fantastic work and experimental transplantation. It's a very large body of work, starting with transplantation in animals, establishing the safety, the modalities were developed, and he started doing it in humans. This was the initial report from the Seattle team in the early 1990s, 100 transplants. And as you can see, the survival graph is nothing to be very happy about. It's about 20% long-term survival. But you must remember that at of time, there was hardly any treatments available for most of the acute leukemias, and almost 100% patients used to die. And with all the limitations of supportive care, availability of many of the drugs that we have now, this is almost a fantastic result, which was achieved by this team at that point of time. Again, when we talk about the stem cell transplantation, two concepts here. One is an allogenic stem cell transplantation. The other one is autologous stem cell transplantation. Allogenic means you're taking the stem cells from donor after doing a matching process, and you do something called conditioning and in the recipient, and you subsequently infuse the stem cells which engraft in the recipient. Stem cell transplantation uses the stem cells from the same person. So this is again used for very specific indications, and primarily the idea behind an autologous stem cell transplantation is to allow recovery of the bone marrow function after use of high dose chemotherapy for certain resistant cancers. So it's almost exclusively done for chemosensitive hematological cancers, the autologous stem cell transplantation. I will again discuss about these coming slides. What is the principle of the stem? And the first thing you have to do is to create a space within the recipient. So you have to ablate the existing bone marrow of the recipient. The bone marrow in the recipient may be a diseased marrow, like in an acute leukemia patient, or it could be a non-functional marrow, like in a patient with a plastic anemia, or it could also be done for certain hemoglobinopathies like thalassemia, when the blood production is abnormal because of the fundamental defect in the hemoglobin. So all these are indications for stem cell transplantation. But the first thing which has to be done is to remove the diseased marrow. How is this achieved? We call this conditioning of the recipient. For conditioning, we use a combination of high dose chemotherapy with or without some kind of a total body radiation. The idea is that the entire marrow system in the body is completely depleted of the existing marrow. And subsequently, when we transfuse the donor stem cells, the new hematopoiesis happens from the donor cells, and you are able to replace the diseased marrow with a functioning marrow. So that is a very simple way of putting the thing. Again, when we talk about the principles of high-dose chemotherapy, especially in the context of autologous transplantation, general concept in oncology has always been that as you increase the dose of chemotherapy agents, you achieve more and more cell kill. So when a tumor achieves a partial remission, that means like 50% reduction, we achieve something called a 1 to 2 log kill of cells. It is generally presumed that in a visible tumor, there may be as much as 10 to the power of 10 cells. So when the tumor size reduces by 50%, actually you've just done a 2 log kills. From 10 raised to 10 cells, you have just gone down to 10 raised to 8 cells. So even with a good response, there is a lot of tumor left in the body. When you get complete response, especially in leukemias, when there are no visible cancer cells, you've still achieved only a 4 log kill. So there's still a possibility of 10 raised to 5 to 10 raised to 6 malignant cells in the body, even when we achieve a so-called complete remission. And this is the reason for relapses of acute leukemias when we use conventional chemotherapy. And this is where the stem cell transplant comes in. Here, we use much higher doses of chemotherapy, and this results in eradication of the tumor and possibly achieving an 8 to 12 log kill of the cancer cell. Obviously, when we use such a high dose of chemotherapy, normally when we use chemotherapy, what happens is you might know that chemotherapy is generally delivered in cycles. Usually these are 3 to 4 weekly cycles. So when we use chemotherapy, we first use we give the first cycle, and the next cycle is given after 3 weeks. The reason for that is that when we use any form of chemotherapy, there will be some myelosuppression, and this happens by usually the second week, and by third week the myelosuppression recovers. So this finally dose just a second. When we use doses of chemotherapy, what happens is the marrow is not capable of recovering on its own. So if you use high dose chemotherapy in the doses that we use for stem cell transplantation and anything, after 3 to 4 weeks, the marrow is not going to recover by itself. It's going to remain ablated. So that is where these stem cells come in. So when we use the stem cells either from an autologous source or from an allogenic source, they allow the recovery of the bone marrow and reconstitution of the. So sometimes the term used is an autologous stem cell rescue because you're rescuing the bone marrow after using high dose chemotherapy. The dose is very critical, and when we are talking about high dose chemotherapy, usually about maybe even 5 to 10 times the conventional doses of chemotherapy, and even minor compromises of the dose can reduce the therapeutic efficacy. So it's very important to deliver the full doses. Usually we use combination chemotherapy to overcome resistance. The commonest chemotherapy agents used for this kind of high dose therapy in the context of stem cell transplant are these alkylating agents. Common drugs are melphalan, cyclophosphamide, and carmazine. That's because they have a very steep dose effect, and as you keep upping the dose of these agents, you get more and more cell kill, and that's what you want in the context of a stem cell transplantation. Other modality used, as I mentioned earlier, is the total body radiation, which may be used by itself or usually combined with chemotherapy. There are specific indications like the acute lymphoblastic leukemia, which can be quite resistant to chemotherapy. And in this context, a total body radiation has some advantages. There are some areas like the central nervous system where the chemotherapy does not penetrate very well because of the blood-brain barrier. So again, in this context, when the disease is involving the central nervous system or likely to involve the central nervous system as in ALL, you would prefer a total body radiation containing regimen for your conditioning. Just a few examples of these conditioning regimens. We use a combination of Bucide, which is one of the commonest conditioning regimens. And there's this combination of busulfan, fludarabine, and ATG. The other component of the conditioning regimen is some kind of an immunosuppressive drug. So it could be either ATG or chemotherapy like fludarabine, which have got a significant immunosuppressive component. Why that is done is because even when you ablate recipient marrow, the immune cells may not be completely ablated, and it could actually reject the stem cells which are. To prevent that, you also have to administer some form of immunosuppression along with the conditioning regimen so that the stem cells that we are infusing into the donor are not rejected outright by the recipient. So the graph components include the stem cell dose. We are also worried about the T cell dose because that is important for the immune reconstitution after the stem cell transplant process. And along with that, there will be some stromal cells which actually allow the stem cells to engraft. When we are giving the stem cells into the donor, actually they are just infused into the peripheral blood, and stem cells actually home into the bone marrow and start growing in the bone marrow. So for that, all these components are important. It's not just the naked stem cells that we are giving. And the host has to be prepared, as I mentioned, with the conditioning regimen along with some kind of an immunosuppression. And in the post-transplant period, we have to use certain drugs to prevent complications like the graft versus host disease. Again, I'll talk about that. So how do you choose the donor for an allogeneic stem cell transplantation? The most important thing is the HLA matching. As you know, the human leukocyte antigen is a series of genes which are present in short arm of chromosome 6. And we have the class 1, class 2, and class 3. So we have a very stringent process of matching when we are planning a stem cell transplantation. So what generally happens is these HLA antigens are usually inherited in the form of haplotypes from the mother and the father. So if there are 4 combinations possible from the mother and the father, as you can see, depending on which haplotypes you have. Within each haplotype, you have the HLA A, B, and C, and you want to match for each of these. And we look at all these matching areas, and generally we talk about a 6x6 match or 5x6 match, depending on the number of loci of HLA which are matched between the donor and the recipient. Most common type of allogenic transplant is done from the sibling of the patient because the sibling is most likely to be HLA matched with the patient. However, you can do HLA match transplant from the general population. These are called unrelated donor transplant. But for this, you need these huge registries which have done the HLA matching for like thousands or even lakhs of people. And you have the HLA reports of all these people available. And then if you have a patient's HLA available, and then you can match within that, and then you can ask the donor to donate his stem cells. Obviously, that is a very costly affair. And even though it has started in India, it's not very popular because of the entire logistics is quite challenging. So bulk of the transplants which happen in our country are HLA match transplant from the sibling, either a full 6x6 match or sometimes a 5x6 match is acceptable. Anything lower than 5x6 is not usually done, except in situations where we do something called a haploidentical transplant, which has got more complications than a fully matched transplant. So as I said, the first step is to harvest. So you mobilize the stem cells. The donor, we give something like growth factors. So GCSF is the one which is commonly used. So we give 4 days of GCSF to the donor, which is quite safe. And after 4 days, the cells of the donor from the bone marrow, they come out into the peripheral blood. And these are harvested. And if they are going to be used immediately, as in the case of allogenic transplant, they can be stored at 4 degrees centigrade. For an autologous transplant, you have to harvest the stem cells beforehand, and then you're going to administer chemotherapy over the next 5 to 7 days. So 5 to 7 days, these stem cells are kept outside the body, and then infused after the high dose chemotherapy is over. Because of that, we have to preserve these stem cells, make sure that they are not by the storage conditions. So there is a cryopreservation protocol wherein we something like dimethyl sulfoxide, which is a cryoprotectant, and these stem cells are frozen at minus 70 or even minus 180 degrees in liquid nitrogen. So, but for an allogenic transplant, mostly it's a fresh infusion. So you just have to keep it in 4 degrees for 1 or 2 days and without any major loss of the viability of the stem cell. The second, of course, is the preparation of the patient with the various conditioning regimens with or without immunosuppression in the form of the various drugs that we talked about. And the third step is the infusion of the graft. And the fourth step, actually the most important step, is the supportive care after the transplant. We generally say that the first 3 steps are the easiest part of the transplant, but the most of the problems happen after the stem cells is given. So these are the mobilizing injections which are given subcutaneously. The stem cells mobilize from the bone marrow into the peripheral blood. And this is the apheresis procedure, which is done for the donor, which is very simple process, just like donating platelets or something. It takes about 4 to 5 hours. And mostly the donors can go back to their normal life the same day. After that, you may or may not have a cryopreservation step. And then you have the high dose chemotherapy and conditioning, which is usually administered in the transplant unit. And if you have cryopreserved, then you have to thaw the stem cells before infusion. And the infusion happens through into the peripheral blood through a central venous access. It's a very simple process. It's just like blood or something like that. Many people have the wrong concept that the bone marrow transplant actually involves pushing the stem cells into the bone marrow. That is almost never done. So you just put these stem cells back into the peripheral blood and they know where to go. They just go and sit in the bone marrow and start producing blood from that point of time. So it takes time, but so after you give the stem cells, the recovery process takes anywhere between 3 weeks. And during that period, the patient can be profoundly neutropenic, thrombocytopenic, anemic. Generally, we see the neutrophil count and the WBC counts go down into single figure, even 0. And the platelets usually drop below 10,000 or 5,000. So we need to support these patients during this period. That is the most critical thing till they start producing blood on their own. It takes about 2 weeks for the newly infused stem cells to reconstitute and produce blood. And when they are so profoundly neutropenic, they are vulnerable to all kinds of infections, bacterial, fungal, viral. So because of that, we generally do this procedure in a stem cell transplant unit, which is air control and it's like a closed bubble where the patients are infections as much as possible. If we have to do a bone marrow harvest, which is almost never nowadays, it's done in an operating room at a general anesthesia from the iliac crest. It takes about 2 hours. Can be done as an outpatient. It's almost as I said, mostly we prefer stem cell collection now. The other source of stem cells is the umbilical cord blood or the placental blood. The umbilical cord is a rich source of stem cells, hematopoietic stem cells. Instead of throwing them, if you can harvest stem cells and preserve them, they can be used in future for some other person who requires stem cells for any purpose. Again, here I want to make a point. There are many in India which kind of purport that you can store your own child umbilical cord blood, and they charge a lot of money, and this is a racket which is going on for quite some time. The important thing to remember is that when we store an umbilical cord blood, it is almost never useful for the same child. It is always useful only for some other person. So storing umbilical cord blood, spending thousands of rupees for any future role of stem cells for the same person is meaningless and should not be done. In the Western countries, they have these umbilical cord blood banks, which are public sector and which can be accessed by any person requiring these stem cells. So the advantage of the umbilical cord blood that it's cheap, it's just available, and you have the ready-made product available. You don't have to call the donor and harvest him at that point of time. However, the quantity of which actually you get from this is quite low. So there's a lot of problem. It's mainly useful only when you do transplants in very small children below 5 years. It's quite challenging to do umbilical cord blood transplants for adults. And the engraftment period, which I mentioned earlier, which takes about 2 to 3 weeks normally. In an umbilical cord transplant, it can take anywhere from even 4 to 8 weeks. So that is quite challenging because you have to maintain a neutropenic patient for that long without infection, without sepsis. Can be extremely challenging in our setting. So umbilical cord blood transplants in India are almost never done because of all these challenges. Very few centers are actually doing this at this point of time. Before infusing these, to check their numbers. There is a certain number of stem cells which are required to be infused for by flow cytometry, and CD4 is the marker which is used to identify the stem cells and to count the stem cells because it's a very marker for the stem cells. Generally, these patients receive prophylaxis for bacterial and viral infections during the transplant process, and they also receive prophylaxis to prevent graft versus host disease in the form of immunosuppression, the commonest immunosuppression used in the post transplant methotrexate for allogenic transplant. You don't need this in an autologous transplant because there is no immune component really there. This is showing the engraftment process post-transplant, the platelets and the neutrophils. So as you can see, if you start the conditioning, the pink graph shows the platelets from about 100,000. The platelets drop to about 10,000, remain low for about between 5 to 10 days, and in the second week they start going up. And generally, once they cross 20,000, we are happy, and the bleeding risk is significantly low. Similarly, for the neutrophils, by around day 5, they become profoundly neutropenic, and they start going up in the second week or so. Once the neutrophils cross 1,000, the patient is generally sick, and we can plan the discharge. Blood group matching is not a must for stem cell transplantation, but if there is a mismatch, we generally do some RBC depletion process that there is no reaction during the stem cell infusion. Matching is not required because the new stem cells and the new which comes after the infusion of the stem cells, the blood group will change for the recipient. Again, for an autologous, this is not an issue. So we generally define engraftment as a neutrophil count of more than 500 for 3 consecutive days and platelets more than 20 days and remaining transfusion free. What are the transplant period that we have to worry about. So the most important thing are the infections. Early period, because of the profound neutropenia, they can get gram-negative sepsis, which is one of the biggest killers in this setting. Because of the low platelets, they can have bleeding. Many of them have very bad mucositis because of the very powerful chemotherapy agents that we have given. Because chemotherapy works tremendously on cells which are rapidly dividing, and the mucosal cells in the gut and in the oral cavity are one of the fastest dividing cells in the body, and they get destroyed. So patients get very profound mucositis, and this is one of the challenges. And they may require total nutrition because they are not able to eat anything. So many of them require TPN for a period of week to 10 days till the mucositis resolves. There can be similarly a gastrointestinal toxicity with profound diarrhea, again because of the mucositis and loss of the gut barrier. Again, the chemotherapy can affect the pulmonary, renal, hepatic, cardiovascular systems, and all these complications needs to be managed in the post-transplant period. Of course, there is this concept of acute graft versus host disease, which I'll discuss in a moment. The late complications, again, infections, in spite of engraft, happens in the second or third week. The immune reconstitution, even though neutrophil counts have come up, the T cells repertoire which needs to be developed may take about another 6 months or 1 year. So up to a period of 1 year, these patients are vulnerable for many infections. It's like something like an HIV positive patient whose CD4 counts are low. So they can get fungal infections, they can get toxoplasmosis, they can get viral infections, cytomegalovirus. So all these problems, in addition to prevent the GVHD, we generally, on top of their already suppressed immunity, we also give some immunosuppression to prevent graft versus host disease. So altogether, these are infections which we have to worry about even up to a period of 100 transplant and sometimes 6 months or even 1 year, depending on how much GVHD and how much immunosuppression we give. Because of the high dose therapy and because of the total body radiation, hypogonadism, infertility is common. Secondary malignancies because of the alkylating agents, you can get late leukemias, and something called chronic GVHD is another problem. And in some patients, about 10%, these problems can run for 5 to 10 years. Also, it's like a chronic immunological condition like rheumatoid or something. So it's not an easy procedure for the patient, and a lot of these issues needs to be tackled as we go along. So just to show some of these infections, this is a pneumonia in the post-transplant period, and this is the severe mucositis that these patients have, and the skin rash is because of the graft versus host disease. Obviously, in autologous transplant, you don't have to worry about the graft versus host disease, but you still have the early infections. Generally, you don't give any immunosuppression beyond in autologous transplant. So once they engraft by 30 days, they are out of the woods, and these people can get back to normalcy. Whereas an allogenic transplant, it takes time, and the other complications, gas extension can run on for many months. So when do we do this stem cell transplantation? Mostly it's done for malignant conditions. Malignancies, the commonest is the multiple myeloma, where autologous transplant is done, and relapsed lymphomas, where we use autologous transplant. Whereas allogenic transplant is commonly done for acute myeloid and acute lymphoid leukemia. In solid malignancies, germ cell tumors which are chemosensitive, and the neuroblastomas and Ewing sarcomas, sometimes we do the transplant, but it's much lesser. There's a bunch of non-malignant conditions where a transplant has improved outcome. Plastic anemia, often the only treatment possible is allogenic transplant. Thalassemias, one of the best outcomes with allogenic transplants, with cure rates of almost 70 to 80%. Many hemoglobin autoimmune diseases like systemic sclerosis can be tackled with autologous transplantation. So you can see the commonest indication is the multiple myeloma, which is one of the commonest hematological malignancies, and mostly we do autologous transplant. The non-Hodgkin's lymphomas are the second common indication, again mostly autologous, and Hodgkin's lymphoma towards the end, that is HD indication. Acute myeloid leukemia and acute lymphoid leukemia, these are again the second and third most common indications. And AML and ALL, mostly we do allogenic transplant. Chronic myeloid leukemia used to be one of the commonest conditions where transplanted. However, with the advent of targeted therapy in the form of imatinib, this cumbersome procedure is not done for CML anymore. So in myeloma, it's even though we don't think that autologous transplant is curative in myeloma, but it greatly prolongs the patient's disease control from about 2 years to about 5 or 6 years. So it's a very important component of therapy and must be done, and the response can be greatly improved with this procedure. In lymphomas, it's mostly done for relapsed lymphomas because once they relapse, generally they are considered to be resistant to chemotherapy, and you need doses of chemotherapy to eradicate the disease. Hence, for most of these lymphomas in the relapse setting, we use high dose therapy with autologous stem cell rescue, and that can cure. There are a few lymphomas where we do it in the upfront setting, like mantle cell lymphoma or T cell lymphomas. We have these registries like the CIBMTR, EBMT, APBMT, that's the Asia Pacific registries, where all the transplants which are done, all the data is captured. Many centers from India also contribute to these registries. So from there, we get these kind of data. In India, the first successful allogenic transplant was done at Star Memorial Hospital, and subsequently in CMC Vellore, where thalassemias were transplanted extensively, Dr. Marwan Chandy. Evolved from a handful of centers in the 1990s. You had just AIMS, PGI, Tata Memorial Center, CMC, and Chennai Apollo and Cancer Institute, RCC Trivandrum. Less than 10 centers. And now we have more than 100 centers doing transplants in the country. In JIPMER, the BMT unit was set up in January 2013, and the first autologous transplant was done in February. And we've done the first allogenic transplant in 2014. Before that, syngeneic transplant, which is from an identical donor. When we talk about it is a tremendous teamwork. It's not just a medical oncology department. We are just managing the patient, but we need a whole team for a successful BMT. We closely work with the transfusion medicine for the stem cell collection and the stem cell required. The dietitian is important, especially when the patient goes into severe mucositis. We need to have a very strong medical backup infectious, because these patients can have complications affecting almost the entire, almost all organ systems can be affected. So it's very challenging. So everybody needs to come in. And before we go for transplant, we have to ensure that patient has no infection. So we get review from because that patient, when we do a transplant, has to be inside the transplant room for a period of 20 to 30 days sometimes, and sometimes even more. So their mental health is very important. The patient should not get frustrated. So do a full psychiatric evaluation, and the patients are counseled extensively. The family is counseled extensively before we take up for this process. I'll briefly talk about our experience. JIPMER, we have a 3-bedded transplant unit, which is a completely sterile area. We enter with air showers, and the inside area is completely HEPA filtered. The FFF unit is in the blood bank where the stem cells are collected, and the stem cell preparation and laminar hood, and the storage is done in a -80 refrigerator. Our data as of January 2019, we have done about 100 point of time, of which majority were autologous, and allogenic was about 16. It's more challenging to do allogenic transplants because the cost is much higher, and only recently we have started getting some increasing. And myeloma and the lymphomas, and so transplant-related mortality is an issue. So in all the transplant, by the is a part of the learning curve, of course, and over a period of time, it does come down. Even then, because of the various complications which can have a transplant-related mortality of at least 5 to 10% for allogenic transplant. So this is something which the patient and the family has to understand before they get into this process. So we these 100 procedures are done for years and hence. So how do we fund this? So some of them we have support, JIPMER being a central government institution, we have some support from the hospital. However, the average cost for an autologous transplant can be anywhere from 2 to 3 lakhs. It may be slightly lower for myeloma, but for lymphomas it may be up to 3 lakhs. And for allogenic transplant, at least 7 to 9 lakhs when you have a full batch. Go up to these 100 were actually able to self-transplant most of these with the help of Veedu and so really to health services, procedures, and we have 2 lakhs available for autologous transplant and 9 lakhs for allogenic transplant. And because of that, our numbers have gone up. We are able to tap into this resource. The challenge now is that we have so hopefully we are planning to expand into a bigger unit in beds and so to do so just skip this. So we have done a few haploidentical transplants in the last 1 year. And, this is the end of coverage on stem cell transplantation. I will. I don't have a lot of time. So I thought the recent advances in cancer is the other part of my talk. I'll just very briefly touch upon one area, the targeted therapy. As you know, the conventional therapy of cancer can be divided into local therapy and systemic therapy. Therapy in the form of surgery and radiation, and systemic therapy in the form of chemotherapy. In the recent times, 3 main things have changed. One is this concept of targeted therapy, or what we call as a personalized therapy of cancer, and immunotherapy and cellular therapy, which I think you've already had a discussion earlier by Dr. Biswajit. So I won't be touching about that. I'm going to talk only about targeted therapy and this concept of personalized therapy. So what do we mean by targeted therapy? So I will try to illustrate that with the help of a patient. So this is the lady who presented with left lung mass and showed a growth, and the biopsy showed adenocarcinoma. And staging showed that patient had adenocarcinoma lung with adrenal and contralateral lung metastasis, which is a stage 4 disease, which cannot be resected, not amenable for local therapy. So the only option available for this form of a systemic therapy with the palliative intent. So most solid malignancies, when they have spread out, reason local therapy is not feasible, they are considered incurable. We take the tumor EGFR is on the surface of cancer. But half of lung and the EGFR is that is the cancer. And now we have specific drugs which can block mutated proteins, and there are many more now. And when we use these drugs, the survival of these patients years. Again, we are not talking about cure here, but it is a very general of the patient and makes a lot of meaningful change in the patient. And the specific cancer protein. Us all. And as them to started on a few examples.
Sir, your voice is feeble. Probably network.
The target HER2, which is a on the breast cancer cells, and about are actually positive for the HER2 amplification, which is chemistry. And when we use trastuzumab in these patients in the adjuvant setting, about 20%. The other important drug is rituximab, which is an E20 targeted drug. Add rituximab to conventional CHOP chemotherapy, you can improve the survival from 60 to here when they became available in the early part of 2000 or horribly expensive and however, the available of biosimilars and generic products, these drugs are universally used. Almost all of the patients get trastuzumab and rituximab, and it has really impacted on the survival of these cancers. We already talked about EGFR targeting in lung cancer. Osimertinib is a more advanced version of gefitinib, and the survival has improved from 1 to 2.5 years. Similarly, you have something called an ALK mutated lung cancer, which is much less common. It's about 5 to 10% of lung cancers. But again, when we use the ALK targeted bevacizumab, which is a targeted agent, which improves the survival of metastatic disease from 18 months to 36 months. And last but not the least, in hematological malignancies, imatinib in chronic myeloid leukemia. Styles of targeted treatments. So when the Philadelphia chromosome was identified in chronic myeloid leukemia, that there is a BCR ABL translocation and there is a BCR ABL. When in the early part of 2000 became available, the survival of this condition increased from about 3 to 5 years normal as possible. Currently, we say that newly diagnosed chronic CML has which is similar to that of the general population. So what we have achieved is that by taking this tablet, a CML can live just like a normal person. We have changed CML from a death sentence into a chronic disease, just like hypertension. Just keep taking those tablets, and patients are almost completely. So this is a very fantastic example of a target therapy in a simple test in these cells. And sometimes you can do a PCR to identify the BCR. Very profound example is the PML-RR alpha, which is a translocation in acute promyelocytic leukemia, also called AML-M3, and retinoic acid. All-trans retinoic acid form of vitamin A is a target for this. It's a drug which again, this particular condition, the survival has almost become 100%. Giving targeted therapy in cancer and personalizing the cancer treatment to the alterations which is found in a particular cancer cell. So currently, when we talk about lung cancer, you have EGFR targeted, ALK targeted drugs, you have other proteins like MET, RET, and you have drugs to target all these. So that's what we say from any lung cancer, we just give pemetrexed and cisplatin. So that's what we used to do in 2000, 2010. Now, any lung cancer which comes, first thing you do is a complete genetic analysis of the tumor, either with focused PCR for identifying these mutations, or depending on what target that you identify, use a specific target, like personalized therapy in cancers. So the future of oncology looks the multiple advances in biology and pharmaceutical science, and this has changed the outlook in many cancers, and this has converted many cancers into chronic disease. And as I mentioned, some of these therapies like stem cell transplantation may be going out of vogue for conditions like CML, when you have a specific targeted drug which works so well. And cure rates have improved in many cancers. Therapies, however, are currently quite expensive because diagnostics are expensive. If you want to do a full sequencing of a lung cancer for all the mutations, you could spend at least 50,000 start treatment. The drugs, especially the newer ones, are expensive, but with time down, accessibility improves because of availability of generics and biosimilar drugs, and Indian companies take it up. So we have been lucky to use many of these drugs in the last few years. And this is our entire transplant team, and outside our transplant youth. Thanks for the opportunity. I hope the presentation you could see all that without much problem. Thank you.
Thank you, sir, Dr. Prasanth Ganesan, for your splendid presentation of such an important subject. Thank you for accepting our invite, and you have presented today in spite of your being sick, but still you have. It was the first event in our college in this new year, and we have started it somehow because of your concern also. Well, begun is half done. Hope we'll be going ahead with our future triple webinars in a nice manner. And sir, you have started with the simple basics of embryological origin of the stem cells, history in brief, in a separate track, and high dose chemotherapy in another track, and then highlighted how the stem cell transplant acts, and elaborated the indications in malignant and non-malignant conditions. So, and you have elaborated the indications and complications also. And many had queries on umbilical cord blood banking, and we came to know how much inferior it is compared to the routine which is being done. And one more new thing which we learned is that even without the same blood group, stem cell transplant can be done. And your team and how you practice really the stem cell transplantation also was elaborated in a nice manner. Thank you, sir. And finally, you have tried to touch the recent advances by talking about the targeted therapy. Thank you once again, sir. Dr. Vishnu, sir, you want to say something?
It was a good presentation, except that towards the end, the connection was, I think, little issue. This targeted therapy you're talking, can it cure disease or only make it chronic?
Sir, it can cure in the sense when we use it in the adjuvant setting, like for breast cancer and for lymphomas, when we use targeted therapies in the adjuvant setting or in the curative setting, it can improve the cure rates. Like what we say is for diffuse large B-cell lymphoma, the usual treatment used to be CHOP chemotherapy. So when we use CHOP chemotherapy, generally the survival or the cure rate of diffuse large B-cell lymphoma was about 60%. But when you add rituximab to the CHOP and give R-CHOP chemotherapy, the cure rates go up to 80 to 85%. So it improves the cure percentage of patients actually. So yes, it does improve the cure also. It's not just about prolonging the life. Similarly, trastuzumab in breast cancer, when we use in the adjuvant setting, it improves the survival of HER2 positive.
There may be some other questions, Dr. Deepa, anybody?
Sir, actually, we got questions in the mail like role of cord blood banking, which sir has explained already. And one more question was stem cell bank in JIPMER, sir. Whether that was the question. Public stem cell banking. That was a question which was given in the mail itself before the presentation itself. I think sir has elaborated that also, and we got response from the participants. Thank you for a very clear, simplified presentation on such a very complicated topic. And basic concepts very nicely explained. Another response we have got. I think sir has explained very nicely the concepts. Even though it is really a complicated topic, it was untouched by many of us. But sir has taken his efforts and he's very much clear with the presentation also. So I think we don't have any more questions. I think whichever questions we had in the mail also have been answered during his session only.
So it was a very nice presentation. I think we should thank Dr. Prasanth on behalf of the management, the institution, dean, the medical superintendent, and all the members who have joined the meeting. I'm sure that everybody is benefited by this. And if there is any troubling questions later, it can be always answered by Dr. Prasanth. He's a very nice person and he'll be available most of the times. So I think he had done a very nice job. He was not well, and I have told him to talk only 3 days back. See how nicely he has presented. I think Deepa, you can conclude.
Yes, sir. Thank you, sir. I should thank Dr. Bhatt, sir, also for us getting an opportunity to get Dr. Prashant sir's such a nice presentation. It was a useful presentation for all the participants today. So, Dr. Shivraj, sir, your phone is please mute yourself. And next week we have a break again. I think we have Pongal next week. Pongal or after Pongal we have holiday. So we'll meet again on January 22nd with a very another presentation in this series 7, Cancer Cure, Perioperative Anesthetic Considerations in a Patient with Malignancy by Dr. J. Vashishta Divatia from Tata Memorial Hospital. So until then, bye from Dr. Deepa, Member Secretary Scientific. Thank you for your patience, hearing, and joining in time. Thank you once again. Thank you, everyone. Thank you, Bhatt sir. Thank you, Dean sir. Thank you, MS sir. Thank you, Dr. Prashant.
Thank you very much. Thank you.
Thank you all.
Hope you get well soon, sir. Thank you.
Thank you.
I have bothered you so much. Thank you, sir.